This is actually very exciting and interesting study with a very novel concept. And obviously, SYNB1891 is a technically STING agonist, and you might say that there are many STING agonists which are currently in the clinical development, but I think this one is a type of compound which really stands out because SYNB1891 is not just a STING agonist, but in fact it's actually bacteria. It's a probiotic E.Coli Nissle, which is a probiotic, presumably harmless bacteria to human, which is engineered to produce cyclic dinucleotides to stimulate STING pathway. And arguably, because, I mean, obviously once the SYNB1891 is injected, it stimulates the STING pathway, but arguably it might also actually stimulate some other pathway, innate pathways, which would be inherent to the fact that there is a present bacteria. So presumably it might also activate some other components of the innate immunity, such as TLR4 and similar, just because of the fact that there is actually bacterial chassis which is present in the tumor and tumor microenvironment. So this one is actually a first in human study which enrolls all solid cancers, including lymphomas. And the drug is given intratumorally. People might say it's a somewhat complicated approach, but it's becoming relatively frequent for therapies using innate immunity. And I think the logistics seems to be well worked out. And it can be injected to superficial lesions, but I think it's also important to know that we have tested injection of parenchymal lesions such as liver, and so far it appears to be safe. The efficacy doesn't seem to be compromised. So we do test SYNB1891 in 2 cohorts, which are kind of opened in so-called kind of a bifurcation type of design, in which we initially started with monotherapy, and after clearing several doses, we allowed dose escalation for combination, which includes Atezolizumab as a PD-L1 antibody as an immune checkpoint inhibitor backbone. We have to date administered 59 intratumor, it's not actually to date, it's to the date of analysis, 59 intratumor doses. And so far the experience has been positive. We didn't have any dose-limiting toxicities. We have seen, and I will talk about it in a minute, we have seen some symptoms which would be potentially associated with cytokine release syndrome, which however were manageable. And as of March 15, we have treated 22 patients in the sites in the United States. And monotherapy and combination therapy are both enrolling at the moment. We enrolled diverse tumor type population, which included cold tumors as well as hot tumors, or immune sensitive tumors, if you will, from melanoma through sarcoma, some adenocarcinoma such as esophageal or colon, lung cancer, that would be small cell lung cancer, basal cell cancer, and variety of other cancers. I said that we've seen some cytokine release syndromes. So I mean, we actually had 2 events, both resolved within 1 day. As far as the injection site reactions, not much, but we had 1 injection site reaction, which was erythema. We obviously monitor also the presence of the bacteria in blood, and we don't seem to be finding any. So it looks like once you administer the medication intratumorally, there is not any leak into a systemic circulation. What I'm presenting at AACR are data on single agent, and which actually was quite exciting. So we have 11 patients presented, and what was actually quite exciting that even from the low dose levels, we actually have seen in some of them activity per RECIST, so which doesn't necessarily include only the injected lesion. Because so 2 of our best patients were patients who had prolonged stable disease with noticeable tumor shrinkage. One of them was a patient with vulvar melanoma who had prior nivolumab, which is a PD-1 antibody, who actually attained stable disease, but minus 28% shrinkage per RECIST 1.1, which was actually pretty close to PR. And that was maintained for a prolonged period of time. The patient ultimately started to lose response after more than 200 days. And came off therapy after more than 250 days. The second patient had a little bit more modest shrinkage, but still about 20% reduction in tumor size with just single agent bacteria. And that was a patient with small cell lung cancer. And that patient actually continues on therapy for close to 300 days at the moment. This program also has quite a heavy translational component. I mean, at the moment, we have relatively limited data, which I was able to present at AACR. And that actually includes the serum cytokines for the monotherapy cohorts. We do see increase in IL-6 and other cytokines such as TNF-alpha, interferon gamma, which seems to be the dose proportional to some extent. Also, we have data on tumors, tumor cytokines and other immune factors. So we do see upregulation in interferon-stimulated genes in certain chemokines, as well as in certain T cell markers such as granzyme A and others. We also present multiplex immunofluorescence staining from the tumor biopsies for the presence of T cells. And the data are actually quite interesting because we present two tumors which would be considered to be immune sensitive or warm, if you will, which is vulvar melanoma and small cell lung cancer. And then side by side, we present tumors which are assumed to be cold, such as liposarcoma and chondrosarcoma. And the change in T cell infiltration for both CD8 cells as well as CD4 cells is actually distinctly different for these tumor population. We do see increase in warm tumors such as vulvar melanoma and small cell lung cancer, but we see nearly nothing for liposarcoma and chondrosarcoma. We also actually look at the nanostring data for the expression of certain markers of interest, which obviously includes interferon-stimulated genes, cytokine chemokines, and T cell function factors. And when we look at the vulvar melanoma, who had shrinkage of minus 28%, I have to point out that this patient was treated on the lower dose level. I mean, we do see increase in STING pathway engagement reflected by increase in interferon-stimulated genes. We do see some upregulation certain cytokines and chemokines, but relatively small changes in T cell compartment. When we look at a patient who was on the higher dose level, the patient with small cell lung cancer, who had about 12% reduction in that patient, we see actually a little bit more increase in pretty much all factors, including interferon-stimulated genes, chemokines, as well as a T cell compartment. These are early data, but the compound seems to be safe. This side effect profile, which you would expect for this class of medication, but so far the AEs, such as mild forms of cytokine release syndrome or injection site reaction, appear to be manageable. We do see early evidence for target engagement and some early evidence for possible early signals of activity, but the study continues for both, for monotherapy and combination arm.